morning, everybody, and welcome to the Iota Live TV and in collaboration with the Volistan Live TV and GE Healthcare. Today, we are on the second day of the Iota Congress here in Leuven in Belgium. So we have different breaks today. So at 10:30, sorry, 12:40, 3:30, and we close the live streaming at 6. So have a nice Congress and talk to you soon.
Definitions to describe ovarian masses, and I kind of think this is one of the most, I mean, everyone here is familiar with these things, but at the end of the day, this is the key part of the whole thing, really, because if you don't get this right, everything else really doesn't follow. So I'm delighted to introduce Lil. Over to you.
Okay. Good morning, everyone. So the publication that I'm going to discuss with you today is this one. Terms, definitions, and measurements to describe the sonographic features of adnexal tumors, a consensus opinion from the International Ovarian Tumor Analysis Group. This is a consensus statement on how to examine, how to measure, and how to describe ultrasound images of adnexal masses using a common terminology. So why do we need standardized terms, definitions, and measurements? We need standardized terms, definitions, and measurements to understand each other in our daily clinical practice. If I say multilocular solid tumor, it should mean the same to you as it means to me. If I say papillary projection, it should mean the same to you as it means to me. And if I quote the size of a papillary projection, it should mean the same to you as it means to me. That is, measurements should be taken in the same manner, irrespective of who takes the measurement. And of course, without a standardized terminology, it becomes meaningless to compare the results of different studies with each other, and it becomes meaningless to join the results of different studies into a meta-analysis. And of course, if we want to conduct multi-center studies, the same examination technique, measurement technique, and terminology must be used in all participating centers. And, of course, for any of the Iota methods to work, you must know and you must use the Iota definitions of the variables in the models. For example, if we look at the Iota simple rules tick box, when we use the Iota simple rules, there are 5 malignant ultrasound features and there are 5 benign ultrasound features. And when we scan the patient, we look for these features and we tick off on a paper form or in our brain the features that are present. If only malignant features are present, the mass is classified as malignant. If only benign features are present, the mass is classified as benign. And if both malignant and benign features are present, or if none of the 10 features is present, the mass cannot be classified using the simple rules. So these are the malignant features: irregular solid tumor, irregular multilocular solid tumor with the largest diameter of at least 100 millimeters, the presence of at least 4 papillary projections, the presence of ascites, and very rich vascularization on Doppler ultrasound. These are the benign features: unilocular cyst, smooth multilocular cyst with the largest diameter less than 100 millimeters. There are solid components, but the largest diameter of the largest solid component is less than 7 millimeters, shadowing, and no detectable flow on color Doppler. So, if the simple rules, for the simple rules to work in your hands, it is obvious that you must know and you must use the Iota definition of solid tumor, the Iota definition of a unilocular cyst, the Iota definition of a multilocular solid tumor, of a multilocular cyst, of a solid component, of a papillary projection, of ascites, and of shadowing. And you must know how to perform a Doppler ultrasound examination of an adnexal mass, which settings to use. And you must take your measurements using the Iota measurement technique. You cannot use your own definitions. Whatever you think about the Iota definitions, if the Iota methods, for the Iota methods to work in your hands, you must use the Iota definitions. So these are the variables that we use to describe an adnexal mass in Iota, and I will now go through with you the Iota definition of a lesion, type of tumor, solid component, papillary projection, incomplete septum, shadowing, echogenicity of cyst fluid, color score, ovarian crescent sign, ascites. I will go through with you how we measure a lesion, a solid component, a papillary projection, and how we measure the amount of free fluid in the pouch of Douglas. So the Iota definition of a lesion is part of an ovary inconsistent with normal physiology. This part of this ovary is not consistent with normal physiology. This is a Sertoli Leydig cell tumor. This part of this ovary is not consistent with normal physiology. It's struma ovarii. And this is a solid adnexal mass. It is not compatible with normal physiology. This, however, is a hemorrhagic corpus luteum, and a hemorrhagic corpus luteum is compatible with normal physiology, so this is not a lesion. Iota definition of solid component. This is extremely important. If you get this definition wrong, the Iota methods will not work in your hands. So a solid component is a structure that has echogenicity suggestive of tissue, such as myometrium or ovarian stroma, and all tissue is potentially vascularized. So the white ball of hair and sebum in a dermoid cyst is not a solid component because a ball of hair and sebum is not tissue that can be vascularized. A blood clot or a lump of mucus is also not a solid component because a blood clot or a lump of mucus is not tissue that can be potentially vascularized. Sometimes, however, it is difficult to discriminate between, for example, a blood clot or a lump of mucus and solid tissue. And then there are some tricks that we can use. We can push upon the lesion with the vaginal probe, and sometimes it happens that these suspicious structures, they lift and move away from the cyst wall and swim freely in the cyst fluid. Then we know it cannot be a solid component. It must be a blood clot or some other amorphous material. And sometimes when we push upon a lesion with our vaginal probe, the suspicious structure starts to move in a jelly-like fashion. Solid tissue doesn't move like that, so this is not solid tissue. It is not a solid component. It is either a blood clot or possibly a lump of mucus. Another trick that we can use to discriminate between true solid tissue, a solid component, and other amorphous material is to switch on the color Doppler function of the ultrasound system. If we then see clearly vessels inside the suspicious structure, we know it is solid tissue. But if we don't detect any color Doppler signals in the suspicious structure, we still don't know. Because the reason why we cannot detect color Doppler signals could be purely technical. Maybe our ultrasound system isn't sensitive enough to detect low velocity blood flow. Maybe our Doppler settings are wrong. Maybe the lesion is situated too far away from the probe for it to be possible to detect low velocity blood flow. Now, if after having applied all these tricks, we still feel uncertain whether a structure is solid tissue, a solid component, or something else, we should classify it as solid tissue. If in doubt, classify as solid tissue. The worst case scenario rules. The Iota definition of papillary projection is also extremely important. If you get it wrong, the Iota methods will not work in your hands. So a papillary projection is a protrusion of solid tissue into a cyst cavity with a height of at least 3 millimeters. This means that protrusions with a height less than 3 millimeters are not classified as papillations when we use the Iota terminology. Of course, a papillary projection is a solid component because by definition, a papillary projection is protrusion of solid tissue. So it's a subgroup of a solid component. This, however, is not a papillary projection because this solid tissue does not protrude into the cyst cavity. The Iota definition of a septum is a thin strand of tissue that runs from one internal cyst surface to another. An incomplete septum is a thin strand of tissue that does not reach the opposite wall of the cystic structure in some scanning planes. And incomplete septa are typically seen in diseased tubes, such as hydrosalpinges. When we use the Iota terminology, there are 5 types of lesion. And again, it is extremely important that you know the definitions of these 5 types of tumor. Otherwise, Iota methods will not work in your hands. So a unilocular cyst is a cyst with one cyst locule, no solid components and no septa. A unilocular solid tumor is a cyst with one cyst locule, no septa, but with solid components, and the solid components can be a papillary projection or some other type of solid tissue. A multilocular cyst is a cyst with septa, but no solid components. So when we use the Iota terminology, even a bilocular cyst is classified as a multilocular cyst. A multilocular solid tumor is a tumor with both septa and solid components, and the solid component can be a papillary projection or some other type of solid tissue. A solid tumor consists of at least 80% solid tissue, as estimated subjectively when you scan through the whole tumor. Using the Iota terminology, there are 5 types of cyst contents: anechoic, low level, ground glass, hemorrhagic, and mixed. These are examples of shadowing. Shadowing behind a ball of hair and sebum in a dermoid cyst, fan-shaped shadowing in a fibroma, shadowing behind papillary projections in a serous cyst adenofibroma. Ovarian crescent sign. Ovarian crescent sign is not used in any Iota model, but I would still like to tell you what it is. When we use the Iota definitions, ovarian crescent sign means that normal ovarian tissue is seen. For example, here we have normal ovarian tissue surrounding the lesion, which means that the ovarian crescent sign is present. Here we see a normal ovary beside the lesion, which means the ovarian crescent sign is present when we use Iota terminology. The Iota definition of ascites is that there is fluid outside the pouch of Douglas, which means that if there is fluid between the uterus and the bladder, there is ascites. The Iota color score is based on subjective estimation of the color content of the tumor scan. A color score of 1 means that no color Doppler signals are detectable. A color score of 2, that a minimal amount of color Doppler signals is detectable. A color score of 3, that there is a moderate amount. And a color score of 4, that there is abundant color Doppler signals detectable within the mass. And of course, when we estimate the color content of the tumor scan, our Doppler settings must be correct. We should adjust our Doppler settings to maximize detection of low velocity blood flow without artifacts. Usually, a pulse repetition frequency of 0.3 to 0.6 kilohertz is optimal. Then you increase the gain until you see color Doppler artifacts appear, and then you decrease the gain until they just disappear. Measurements, how do we take measurements when we use the Iota measurement technique? We always measure 3 orthogonal diameters, 3 diameters at right angles to each other, and we take these measurements where we estimate that the lesion, the ovary, the solid component that we are going to measure appear to be at their largest. So if we want to measure the size of a lesion, we first obtain a longitudinal section through the lesion, and we measure the length and the anterior-posterior diameter of the lesion at that longitudinal section where we estimate that the lesion is at its largest. Then we turn our transducer 90 degrees to obtain a transverse section through the lesion, and we measure the width of the lesion on that transverse section where we estimate that it is at its largest. How do we measure a papillary projection? We always measure the largest papillary projection, and we measure 3 orthogonal diameters. When we measure the height of a papillary projection, we should not include the cyst wall or the septum from which the papillary projection arises in our measurement. How do we measure fluid in the pouch of Douglas? We measure it on a longitudinal scan through the pelvis, and we report the largest anterior-posterior diameter. Again, fluid in the pouch of Douglas is not included in any Iota model. I just mention it. So now I have discussed with you the definitions of lesion, type of tumor, solid component, papillary projection, incomplete septum, shadows, echogenicity of cyst fluid, color score, ovarian crescent sign, ascites, and I have discussed with you how we measure the size of a lesion, a solid component, papillary projection, and free fluid in the pouch of Douglas. Thank you very much for your attention.
Lil, thank you very much. Key lecture in the whole program, basically. Any comments or questions, or any areas of uncertainty about any of these features that people have kind of been scanning and thinking that they didn't make a lot of sense, or confuses them at all? Antonia, anything to say?
Thank you. Thank you for your lecture. I'm here.
Where are you?
Here.
The lady with the yellow box, yes.
A small question. Big cysts, clear, and then you have those very small cysts at the base. I mean, can you... Very small, very small.
Yes.
So that, I mean, it really takes an effort to see that they are molecules, in the beginning you actually think that it is a sort of a solid part, and then you have a good look
sort of
a solid part, but then when
solid
you have
part.
a good look, you see that they are just small
Yes, yes.
locules or very small cysts. And
yes.
would you describe it as a multilocular?
I would, yeah.
You would describe it as a multilocular?
I would. I don't know the rest of the Iota steering committee, but I mean, by definition, if there is more than one cyst locule and no solid components, it's a multilocular cyst, and I can exactly imagine what type of cyst you are referring to. One big cyst locule, and then you have a little conglomerate of small cysts.
Exactly.
So if you have an overview of that cyst, you might think it's a papillary projection, but when you zoom in the conglomerate of small cysts, you can see it's actually not a solid component, it's just
small
a
cysts.
conglomerate of small cysts.
Okay.
Very often this is referred to as daughter cyst,
Yeah.
daughter. And this is very suggestive of a functional cyst, so very often this will disappear. So that's why many multilocular cysts are disappearing. So then you only have two locules, one very small, one big, and very often this will disappear in a few weeks' time. And again, if you're not certain whether it's a real cyst or whether it's functional, it's always a good idea to ask the patient to come back. And you might ask her to come back at another phase of the cycle. For example, in 6 weeks' time, and then this cyst will probably have disappeared. So there's no shame in asking the patient to come back if you're not certain whether it's a lesion, according to Iota, or not.
Any other queries on
Yes.
definitions?
Thank you very much for that very clear presentation. The doubt is, you said papillae are ones which 3 millimeters or more. And there is an Iota benign feature which says it should be, a solid area less than 7. So, it's just, you said there is a wall irregularity if it is less than 3.
Yeah.
So how do these 3 fit in? Probably if you see one solid area less than 7, then you take it to be not a papilla and a solid area, or...
Well, when we created these simple rules, it doesn't make a difference between a papillary projection or another solid component. So in fact, if you have, if you use the simple rules, if you have 3 papillary projections and none of them has a largest diameter, 7 millimeters or more, it can be classified as a benign tumor, unless, of course, there are malignant features as well, other malignant features. It seems a bit contradictory, I agree, but the simple rules are based on thousands of patients, and this is what we came up with. As long as the solid components have a largest diameter less than 7 millimeters and no malignant features are present, it can be classified as benign.
Thank you. One more question. A dermoid is unilocular solid.
No,
Okay.
it is not.
Okay.
It depends. maybe. Sorry.
Okay, Lil.
But
I think we got the message, Lil. That was
Sorry. In theory, you can have a dermoid cyst with a solid component, but the white ball, the typical ultrasound image of a dermoid cyst, one cyst locule and a white ball of hair and sebum, it's a unilocular cyst with mixed echogenicity because the ball of hair and sebum is not solid tissue that is potentially vascularized. It is amorphous material. It is not a solid component, and this is very, very, very important.
Thank you.
So there you go. Don't mess with Lil Valentin. Okay. Any other comments, questions? No?
Yeah, there is one.
There is one. Sorry. Where are you? Put your hand up. There we are.
Oh.
Okay.
Good catch.
Terminology for CT as well, or is it really just for ultrasound?
I would say it's just for ultrasound. We know nothing about CT and MRI.
You're just a whole different world to us.
Yeah, because right
well,
now...
I mean, they've never been developed for use in CT. Is Andrea Rockel in the room, as it were, somewhere? I mean, certainly there are. I mean, there's this new URAD system for MRI, which you'll be familiar with, where they're sort of developing a similar approach to looking at MRIs, and there seem to be analogies with the Iota system, but obviously no. It's not been validated in CT or MRI, but I mean, it would be interesting to see. So we'll have you back in a year and see what your data's like. So I think it's, because it would make sense, and I can't see why they wouldn't be analogous. But it would be interesting if you, from now on, in a sort of applied them in a research context and see if they worked. Andrea's here somewhere, is she? Yes. Did you hear the question? The question was, can we use Iota terminology in the context of CT? And I was saying, well, you've developed URAD, which is an analogous system but different, and obviously no one, to my knowledge, has applied this, but in some senses you're looking at similar features and probably we're looking at the same things. But anyway, I thought perhaps you could comment.
So it's a great question, and it's something that we've been thinking about a lot. And as Tom and Dirk know, we're at the moment working with the ACR, the American Congress of Radiology, to try and align the ultrasound and the MRI lexicon and terminology. And we have tested various items which we've pulled from Iota on MRI retrospectively. We've now finished a big prospective study in 1,400 patients led by Isabel Thomas-Nagara. I don't know if she's here. And those results are just, we finished all the results for the patients who were operated on, so we can see how the terminology works in MRI for those. But we don't want to publish really until we've got the follow-up patients that weren't operated on. In terms of CT, as you know, as a radiologist, it's really difficult to see the fine detail. But we discussed in the ORADS committee whether we should, in the first wave, try to incorporate CT features as well. But we decided initially we're just going to set out the MRI. But in the background, we're collecting data now on the CT. And then when we've got the ORADS, hopefully the ORADS classification sorted out with ACR and the MRI, then we might take it forward with the CT. But it's much more difficult, as you know. Yeah. Thank you.
Thanks, Andrew. Sorry I thought I put you on the spot there.
To your left here.
Left.
Up here to your left, Tom. Up here. No, to your right. Sorry, I'm sorry. Sorry, it's my left. It's my left. Sorry.
Hello.
I just want to make sure I've got this right. Okay.
Yes.
So a lesion is to do with an ovary, yeah? You're talking about physiology of the ovary, yeah? Because any para-ovarian lesions, like, for example, hydrosalpinges, etc., can we use the definitions that you're using in the Iota for those? Because that's what you started the lecture with, is a physiological changes of the ovary. Anything that comes out of that is a lesion. But when I scan many times, I see a lot of para-ovarian lesions. So am I allowed to use these definitions or these parameters for these para-ovarian lesions?
Yes, you are. Because, the terminology and our methods, the Iota methods, they are actually based on adnexal lesions, and included in adnexal lesions are diseased tubes and para-ovarian cysts also. But of course, the vast majority of the lesions that we have used to create the methods are ovarian lesions. But they should work also for non-ovarian adnexal lesions.
Anyone else to my left or right? There is someone. Is there? There we go.
I just wanted to ask if you have any special way of detecting lesions which are infiltrative, sometimes very...
Which are?
Infiltrative lesions, like, for example, lymphoma or some metastasis that simply enlarge the ovary, but they are very difficult to delineate perfectly as a mass. Is there any special way to detect these lesions?
Well, we have a specialist here in the audience, Antonia Testa. I mean, we have published papers on, we have published descriptive papers, just describing the ultrasound features of different malignancies, including metastasis in the ovary, from breast, stomach, lymphoma, etc. So we have an idea of what they usually look like on ultrasound. But that's a whole lecture.
Yeah, I mean, sometimes it's very difficult to know exactly where the size of the lesion is, because the ovary is enlarged, but not really like a mass that you can measure.
I don't know. Would you like to say something? I don't know.
Difficult to tell you some tricks, because I understand absolutely what you say. The difficulties, especially if you see the natural history of a metastasis, who knows? Usually we can detect them as bilateral, 6, 7 centimeters, and that's easy. But it's difficult to see some nodules growing and to understand, is it a lesion? Is it an enlarged ovary? Difficult. Okay.
Right? Pardon? You want this one?
I want that one. I was going to use that microphone, but I was going to say, Salil, thank you very much for a great talk. Really important part of the program, and always raises a few questions, interestingly, because people often have queries about how to interpret these things, I think. So, Salil, thanks very much. Can I just sort myself out here? Is that right? Am I on? Perfect. Can I change slides with that? Okay, perfect. Right. Well, you got me now. Bad luck. So Dirk has asked me to talk about descriptors and pattern recognition to recognize ovarian masses. And I kind of was a little uncertain about doing this because it's a bit basic. But on the other hand, you know, it's something which actually we all do. Because one of the arguments I always had about Iota was that, you know, and in fact, where are you, Povlas? Yeah, very difficult man. He yesterday said, well, look, why are you doing all this stuff? And we showed a video, because I just know that, you know, that's what it is. And of course, that's how most of us scan. You kind of see something, and actually you say, yeah, I know it's a dermoid. And possibly one of the biases in the Iota database is that people will see it, it's a dermoid, and then almost go backwards in their heads to find features that they kind of know are dermoids, you know, like, oh, it's mixed echogenicity, and oh, there's acoustic shadowing. So, you know, it's almost inevitable that you'll have these characteristics coming out in the database, that's actually how you define these things. So it's very kind of you, Dirk, to invite me to, again, to Leuven and to Gasthausberg. It's such a well-resourced hospital, and I don't know about any of you, I always say this to Dirk on this slide, every time I come here, this hospital seems to grow bigger and bigger and bigger. And here we have the hospital, and just over here is Leuven. And it's something I have never understood. What the hell all these people do here when there's about 10 times more people work in the hospital than actually live in the town. But anyway, I'm sure it's, so I'm not sure. Either they've got a lot of money or they're incredibly unhealthy people, but it's very hard to tell. So, pattern recognition. We're fantastic at pattern recognition, actually. So all of you will look at these, and what do you see? Faces, right. I mean, and it's quite unlikely, isn't it, that here you have a breakfast and you eat a face. Zip, you have a fish. You know, you make these conclusions because you put together very few little visual clues and kind of put it all together. And I've forgotten the term. It's like pareidolia or something, which is a tendency to see things in patterns. which is sort of hence things like the Turin shroud, in my view. Sorry, Antonia. But anyway, I think it's a tendency we have to do this. And you can get more sophisticated and actually think you can see bits of art from Norway sometimes, even in electrical devices. So that's quite impressive. So we are naturally made to recognize patterns. And it's just a question of familiarity. So, I know what Dirk Timmerman looks like because I've seen him quite a lot, right? And since I was born, I've seen faces and loads of faces, so I'm good at it. And actually, scanning is exactly the same. Just to illustrate the point, you can see here this bunch of characters, which I found online. And this group of individuals are extremely trustworthy, upstanding individuals, and the rest all have slightly concerning tendencies, I understand. Sorry about that one, right? It's the only one I could find. It's not your best shot, I have to say, but never mind. But the principle, of course, is that all of these people you'll pretty well instantly recognize, more or less. And, of course, it's because you're very good at pattern recognition. Now, this is what happens if you let a gynecologist bake rolls in the kitchen. I know most of the people who actually know me quite well will find it rather unlikely that I actually did this, but what would be the gynecological role here, as they say? There you go. So this is, as we say, coronal plane, and you can see patterns almost anywhere. So here we have, obviously, a uterus with a woman with rather a lot of ovaries, rather unlikely. But you've got to be careful, because we do tend to con ourselves and fool ourselves a little bit, because when we make decisions, we have biases, and we have cognitive bias. So we have availability bias and various heuristics which we use to shortcut based on our experiences. And sometimes that can let us down, because we think we know what we're looking at, it seems so familiar, but actually the circumstances are slightly different. So, if you read that, do you want to read it? What is it? So it's ABC, but it may not be, okay? And that's a well-known bias, in other words, is that you interpret that based on what you see around it. But there's absolutely no difference. Okay, so it's availability bias. You actually say, well, okay, I've seen that around it, this is what it must be. And actually similar things happen in medicine where you see a pattern of features. It all seems to fit together because you've seen that before, but actually it doesn't always work out that way. And actually with imaging, it's the same thing where you can get that kind of thing. So this is I'm not being unfair, everyone says the same thing. And this is I always love this slide because they showed it to a bunch of radiologists and cross-sectional images in America. And who can spot the abnormality? Put your hands up. Yeah? Anybody? Who should we ask? Who should we ask? We'll ask who? Luca Savelli. What's the abnormality? What, you think this is a metastatic lesion? Well, can I give you a bit more history? She's 35, okay? She has a history of ovarian cancer. What do you think? Well, the answer is she's actually got a gorilla up here, okay? Which is an unfortunate problem you get occasionally, this kind of metastatic gorilla problem you get. But, I mean, it's just it's a game, and they showed it to radiology, and of course people just look, and they're so focused on, thinking, what's going on? Where's the lesion? That, of course, this is entirely incongruous. It's completely not what you expect to see. So you simply don't see it. So apologies to pick you out. But I'm just trying to illustrate how your mind can kind of, it's easy to either not see the wood for the trees or to be led astray by stuff that's going on around it. So if you see a scan, it looks obvious, but actually it's not quite what you've seen. And that's based really on sort of cognitive function. And Daniel Kahneman, who got the Nobel Prize for cognitive theory, obviously it's a lot more complicated than I'm making it out to be, but it's kind of worth reading his Nobel Prize-winning lecture. And actually, I think he wrote the book Thinking Fast and Slow or whatever. It's a good read. And essentially, it comes down to System 1 and System 2 thinking. And what I'm going to talk about very briefly, actually, because we're going to go through these descriptors, I'm more interested in why they work, is that, our instant response is based on memorable examples. We have shortcuts, cognitive heuristics, and emotional things, and we sort of say, I know what that is, bang, straight away. You make a decision, and you have these instant decision-making processes based on your prior experience. But if that doesn't work, then you have to fall back on other things. And sometimes that involves statistical thinking, asking other people to look at things, and actually a more measured response. So it's a bit like going into a shop and buying something just on impulse because you want it, you think you need it, but then sometimes you have to step away and think, actually, really? But actually we do the same thing when we look at situations in medicine. We've seen it all before, we think, and therefore we instantly decide what it is. And then what happens is, as I said before, you kind of work backwards to justify your decisions. And these are all biases, they're all cognitive biases. So you anchor yourself, for example, based on your initial impression, you keep referring back to that and justifying your initial bias. But actually, with a lot of situations in ultrasound, you have enough experience of seeing relatively straightforward stuff that your instant response is pretty much going to be correct. So obviously, if you look at these masses, straight away you'll say, yeah, whatever, dermoid endometrioma, and then you can spend the rest of the time scanning, trying to justify the time with the patient, otherwise it looks a bit bad because you've only been like going, yeah, fine. And then perhaps if you have these masses, you have to think a little bit more and think, well, what are they? And either you're going to say, well, actually, in my experience, I know exactly what this is because there's acoustic shadowing and all the rest of it, or you might say, actually, I'm not so sure, maybe I used to need a model, or maybe I need to get someone else to have a look at it, because you need to take a bit more time. And that's really what the whole premise is of descriptors. So descriptors you can apply when you have a lot of familiarity, they're very straightforward, they're typical of the particular type of lesion. So this is a typical endometrioma, and we always know there's some others which are not so typical. So it doesn't apply to all endometriomas, but there's the ones where you just like, I know that's what it is, then it's fine to use them. And so when we talk about descriptors, it's self-evident that they don't apply to all masses because not all masses are typical. So they're only going to apply to maybe 40%. But it means that there's a whole bunch of masses you can say, I know what they are, that's fine. And then the rest is where you need help with models or rules or whatever else. And that's basically what Dirk's going to talk about after me. If I ever get off stage, Dirk. So here we have how I would say we use descriptors. So you have system one thinking, you have your index case, and basically you say, I've seen one like this before, but then depending on how many or what types of masses you decide to apply there, you may or may not have seen a lot like that before. But for most people, relatively simple cysts, simple endometrioma, simple dermoid cysts, obvious cancer, will fit into this kind of category. And you have to be aware that there are various biases I've talked about, but in the other masses, you have to employ system 2, which in the context of Iota would mean some sort of algorithm to help you or help people make a better decision, which is the whole point. So going back to Povilas's point yesterday, sure, probably the more experienced. Now I'm just going to talk about the descriptors for some relatively straightforward masses, but people like Lil or Povilas or whatever will actually be able to have their own descriptors in their heads, as it were, where they'll instantly know what stuff is. And Lil did it yesterday. She's just like, oh, that's a Leydig cell tumor. Well, most people in the room wouldn't do that, but she's super familiar with it. So she can cut through everything else and just come up with the answer because she has a database in her head of having seen these examples in the past because she's seen a lot of it in the past. So what are the descriptors? I think you're all familiar with this, and the fact is that there are some pathologies where a number of these particular types of pathology have fairly standard features. And there was nothing clever about these. I mean, I sat in the Klooster Hotel with Lieveke Ame over a beer and said, right, well, actually, if some of these are things we are pretty certain, if someone has a unilocular cyst with ground glass contents and no other features, it's going to be an endometrioma. So we kind of looked at that and then analyzed the database. It wasn't based on some huge statistical analysis. But simple cysts, dermoid cysts, endometriomas, advanced cancer. And they exhibit typical features. You don't need models. It's intuitive. And the question is, how many masses can these be applied to, and how do they perform? And very, very quickly, because I think these will be familiar, the descriptors, there are benign descriptors, which are basically unilocular ground glass in a premenopausal woman, and obviously that's designed to pick up what we would call as typical endometriomas. Similarly, unilocular mixed echogenicity, which is just a fancy way of saying typical dermoid cysts, and you can see examples of these here in premenopausal women. Unilocular, anechoic, regular, maximum lesion less than 10, so, simple unilocular cysts less than a certain size, and then the rest of the unilocular cysts. And I'll just talk, we initially didn't put less than 10 centimeters, but we probably should have done. And you can argue, actually, you could amalgamate both of these into unilocular cysts of less than 10 centimeters, but this is the system we came up with. And then for cancer, it was the presence of ascites, which self-evidently is going to be a very high predictor for cancer, moderate colour Doppler blood flow score 3, and in a postmenopausal woman. Just to remind you, because yesterday there seemed a little bit of confusion, that colour score of 1 is no flow, not 0. That's not in the thing. So you can look this up. It's just a very simple subjective assessment of colour. But people sometimes, if you ask 20 people, they'll put slightly different scores, but generally it works pretty well. So, and this is the last one, and that is a woman of over 50 has a CA125 of over 100. So if someone in that situation with a mass, they're highly likely to have cancer. So they're really simple, really straightforward, not complicated at all. Anyone can use them. So the question is, how do they perform? Very quickly, this is looking at these different features and their performance in Iota phases 1 and 2. So it's about 3,500 masses. We found that the descriptors applied in 40%, 43%. So it's a fair number. You can just say, these descriptors apply, I know what this is, I don't need to do anything else. And if you look at the overall performance of these, you can see for the various descriptors, just looking at the correct outcome in terms of diagnosis, benign versus malignant, for all of these benign descriptors, it's a very good test, works very well. And indeed, you'll get the specific histology right, as you might expect when you're using things, when you're using these to sort of predict a dermoid or an endometrioma. So it's specific in terms of what the pathology is, and it's a good test for saying whether it's benign or malignant. And we've got the same situation with these straightforward malignant descriptors as well. So if you are in this situation, you are highly likely to have cancer. And I would argue that if you have these and you can apply them, and you'll see what Dirk has to say, you don't really need to be using models and things like that. Because, I think that's how we all scan. You say, yeah, I know that, but this I don't know. And the question then is, how do these models, the Iota models, and so on, work if you take these masses out of the database, as it were? What happens when you then apply these models to the residual masses? Because obviously they're a different population to the type of population we develop the models on. So that's the question, and that's something we can debate. And that's published here, and you can look it up. So we've also had a look at the data from the Iota 3 study. It's a different data set, pretty much the same, if you can look here. For the 3 benign descriptors, just to remind you what they are, you can see that percentage malignant, if the benign descriptors were applicable, was 0. This descriptor, remaining unilocular cyst, when we got this number was because we didn't put in the caveat that it should be under 10 centimeters, but if you apply that, then there are no malignancies for that descriptor, and obviously you can see the likelihood of cancer is extremely high. So this seems to be pretty consistent in different data sets. I've pretty well said that already. So, do they work when we have sonographers? Is Ahmed Sayasna here? Where is he? You're sitting up there now. You're not going to come and sit down here on the chair then, is that right? Like yesterday. Okay. So Ahmed did this study, which I thought was important because people often criticized the Iota things and said, oh, you're all experts, that's how you got the data. This is carried out by Ahmed, who at that time was a resident and sonographers. And you can see here that the descriptors work well, almost exactly the same, and also with a very high specificity in terms of being very specific about the pathology as well. So they work both in the hands of so-called experts, and they seem to work with residents and sonographers as well, as you can see. And interestingly, in the hands of these people of different experience, although you didn't get it right all the time, if people thought, said, I think it's X, Y, or Z, if the pattern was fairly typical, it's fairly clear that you're going to get it right most of the time. It's people are quite specific. Once people have got to a certain level of experience, if they recognize a typical pattern, then usually they're fairly specific about it. I won't talk about the torsions. And I'll finish at this point, because I think this is where I should be handing on to Dirk, because we've talked about how these descriptors work. And clearly, if you look at this paper and more carefully, what we did, we tried to look at how, if we use easy descriptors, then apply the rules or different models, how what the test performance was like, essentially. And I think this is something Dirk's going to move on to. So I'll finish there, and perhaps we can hand over to Dirk to talk about the next sort of step, if you like, where what do you do if you use rules and then a model, and then we can have a discussion after that, I think would be the sensible thing to do. So I think that's it. There we go. So it's basically pattern recognition is the message. So Dirk, do you want this, or are you going to talk on? Yeah.
Thank you, Tom, for this brilliant introduction of the easy descriptors. And easy descriptors were really invented in Kloosterhotel together with Lieveke May, who was there then, and Tom simply said this and this and this. She did the analysis on the spot, and she was very much impressed by your predictions. But now I guess most of you are completely confused. Yesterday we've seen a lot of new research. Today we've seen a very clear and very precise introduction on terms and definitions by Lil. Then the reality check with Tom in clinical practice, you will not scrutinize, you will not analyze the very easy tumors, you will not use a model for them. So how would we do it in reality, in clinical reality? And maybe you have your app with you, the Eventigrate app, and this is not a quiz where you will win something. You will win something if you visit a booth, and then this afternoon there will be again a beautiful prize. So please do so during the coffee break, and this time we will be on time for the coffee break, so you will have some time. But now you can take your app and you can vote. And my question is, at this moment, what you know, at this moment, what you've seen the day before and today, what would you use to classify an Excel masses? If you think subjective assessment is the best, and I will use from now on only subjective assessment, you press 1. Or you can say, I like the next model, so I will use it in all cases. Or you can say that you use a simple rules in all cases. You can use another model. Maybe you're a fan of the risk of malignancy index or any other model. Then you press 3. If you think that, no, that's 4, sorry. 5 is easy descriptors, and then the next model for the more difficult cases. And 6, you first use the easy descriptors and then another model for more difficult cases. Can you vote now? Is it working? Do you find it now? No? Okay, then raise your hands. Who would use subjective assessment? And yes, but that's difficult because he's here, so he cannot put a... Thank you so much. He cannot multitask, he's a man as well, so... So raise your hands, subjective assessment. Okay, so we see the Subjective assessment 7%, at next model in all cases 14%. The simple rules in all cases 11%. Another model in all cases 18%, so that's worrying. Then use the easy descriptors and then the next model, that's 32%, and then easy descriptors and another model in 18%. So it's quite a different opinion in the audience. And the ones who voted for the 18% in other models, which model would you prefer? No reply, they don't dare to reply.
I think the
Okay,
RMI.
so we go further. So, like Tom beautifully introduced, we have simple cysts, we have dermoid cysts and metiomas, advanced cancers, and they exhibit typical features. And most of you don't need any mathematical models to use for these tumors. So we tried to have easy to classify ovarian tumors characterized by these descriptors. And then before we tested how RMI, LR1, LR2, and the next model would perform in these cases. And you've seen this slide in unilocular cyst, unilocular with mixed echogenicity, suggestive for dermoid, unilocular with ground glass appearance, and the remaining cysts, it was a very high correct outcome in terms of benign and malignant. So the question is if we only limit it to these cases, because as soon as you go to malignant predictions, it's not almost 100% certain, and maybe in these cases a model could be helpful, because if you think it's malignant, it's not enough. If you use the next model, then you know it's probably borderline or it's more likely to be a metastatic tumor. So this might help you. So therefore, we believe that a model is still of value in the malignant easy descriptors as well. So let's focus now only to this, and I'm very grateful to Chiara Landolfo, who presented this for the first time at the ISWOG World Conference in Rome in September. And what we did was we checked the Iota phase 3 study, so it's a big study of 2,400 patients, and we looked at different steps. So the first step is application of the easy descriptors. And then, as a second step, we looked at how is the performance of the risk of malignancy index in these difficult cases, how is the performance of the next model, and how is the performance of the new simple risk prediction model that can include all the patients, because as you've known, the simple rules are not applicable in, roughly speaking, 20–25% of patients, because either there's no benign features or and no malignant features, or you have conflicting features, benign features and malignant features at the same time. So step 1 was easy to apply. Step 2 as well, for the statisticians, that was no problem. We limited to the benign easy descriptors. And in this big study, performed in 18 centers, and most of the centers are represented here today, and thank you for this. The study was performed between 2009 and 2012, and it's called Iota phase 3. So again, like always, there should have been at least one adnexal mass, so it could be either the ovary or the fallopian tube. But the inclusion criteria was that at least one ovary would be left in a patient. Preoperative standardized transvaginal sonography was performed, and histology was the gold standard. But the patient had to be operated upon within 120 days after the ultrasound scan was performed. And then the performance of the two-step strategy was assessed, sensitivity at 80% specificity, and also the results were computed using meta-analysis technique, because our statisticians convinced us that meta-analysis technique is better than simple analysis. And based on this, 2,403 patients started, and the easy descriptors, the benign easy descriptors, were applicable in as many as 42%. And you can imagine, these are all patients who were operated upon. So if we would apply the same strategy in Iota 5, we would have many more patients in the easy group. Because in Iota 5, there's a lot of simple cyst, benign-looking tumors, unilocular tumors, endometriomas, dermoids, which are not operated upon, and they are not in this study. So the proportion of easy descriptors that are applicable would have been much higher if we apply this in real life. And then we are left with the difficult ones, so because the easy descriptors are not applicable, I know it's not always difficult. In some cases you will immediately say this is cancer, but at least these are not the very easy ones that you immediately spot and say this is endometrioma, this is a dermoid. And then there was the application of the risk of malignancy index, the simple rules risk model, and then at next, and in this analysis, it was analyzed with C125 and without. And it becomes clear to you that the risk of malignancy index, which we heard yesterday, is still the gold standard test in the UK and in different other countries. And therefore, I still think it's ethical to do this randomized trial in the Netherlands. I think it's an excellent idea, because without randomized trials, without good evidence, guidelines will never change, because it's so difficult to change a habit. The risk of malignancy index was developed in 1990. So it's been there for so many years, so it's very difficult to change something. People are very reluctant for change, and especially if you have to study for a new thing. So that's why we try to make it as easy as possible. So we hope that this would be digestible, but you can immediately see that the risk of malignancy index is really not a very good second stage test for these difficult tumors. Simple rules risk model, as published in the American Journal in January 2016, is a good test. So the area under the curve is 0.85. And the application of next with C125 was 0.86. This is not better, but you can see this is certainly a very good candidate test in this way, used as step 2 after the application of easy descriptors. And here you see the sensitivity. The next with C125 has a sensitivity of almost 92%. And next without C125 is almost the same. Simple rules risk model is 91.5%. And the sensitivity for cancer by using the risk of malignancy index is only 81%. So I think what other evidence do you need? Do you need a randomized trial? Yes, I think we need a randomized trial to convince people. But on the other hand, to me it's clear that you should better use the next model as a second stage test. Because the next model will give you also the differentiation between different types of malignancy. And if you use the benign easy descriptors in Iota phase 3, they almost work perfectly, because 40% were classified as benign, and all of these cases were benign except 2 cases of borderline. And as Tom correctly says, we should have applied that the maximal size of the simple cyst or the unilocular cyst should be 10 centimeters. And if it's above 10 centimeters, be careful, because you might miss some small wall irregularities or papillations. The easy descriptors is good first step, and in adnexal masses where benign easy descriptors do not provide the diagnosis, you can either use the adnex model or the simple rules risk model. But I prefer the adnex model because, like we said before, it gives you a better choice. And now I'm afraid of having this vote again. Thomas, are you ready for voting? Yes, so you can vote again. Exactly the same question. What would you use to classify adnexal masses? Would you use subjective assessment in every single case, press 1. Use the next model in every single case, press 2. Simple rules in all cases, 3. Use another model, risk of malignancy index, or another model, press 4. Easy descriptors, step 1. Step 2, the next model, or easy descriptors, and then another model. Did you vote? I beg your pardon? You haven't seen the questions? Okay.
Did you have a questionnaire? How many no? No.
Okay, can we try again? Not? Can you raise your hands? Who would use for option 1? No. This is a psychological pressure because now it's not anonymous voting anymore, so I'm so sorry for this. But look, it's there. Thank you. You can still vote, I think, so you can still influence the results. You're too kind. Thank you so much. So in conclusion, more than 50% of people in this room would be convinced that easy descriptors as a first step are a good diagnostic test, and then application of the next model for all the other cysts would be a very good second stage test. Thank you.
Okay, Dirk, thanks very much for that. I think that was clear. It's interesting, isn't it, how that's sort of changed over time?
Well, there was really psychological pressure. If it was by voting, so everybody would.
Well, there you go.
That was unfair.
So what are we doing now?
Luckily, the system solved the problem.
Now we've got Lil. Lil is going to come here. We have a
Lil,
discussion. Is there a microphone for Lil?
These are very comfortable seats.
We're having a comfortable seat. I don't know how many microphones we've got, so maybe Lil can have a microphone. You're looking very cozy there, you two. Do you think there's any issues about, just going back to Lil's talk, about the Iota definitions with respect to definitions?
Maybe you can have some light in the room as well, because then we can see something. Yes, perfect,
so
thank you.
We've kind of got Lil and Dirk here, so in a few moments to have a discussion about issues to do with Iota. So if people have any questions, really, I think, put your hand up, ask them. There's a gentleman there. I'm just going to say, do you think there's any... There clearly is a little confusion that came up in the discussion earlier about this issue of solid tissue, and I do think it does elicit some confusion that a benign feature effectively can be a 7, and then a number of papillations is defined differently. Do you think there's a way to rationalize that, or if we had the time again, would we do it differently?
Well, I'm very much looking forward to more evidence from Iota 5. Because as Wouter beautifully showed yesterday, the ones where there was malignant transformation, they were more likely to be unilocular with small irregularities. So some cases that look a little bit like serous cystadenofibromas may change into something that is... So in that case, it's even not a population if the height is less than 3 millimeters. And still, you need to be aware that if the wall is irregular, more supervision of the cyst is needed. So I think these are, but at this moment, we have not fully analyzed the Iota 5 study, but I think we will have a better answer to this. And when we started the definitions in 2000, we had many meetings with Lil, you, and we had evenings where we made many drawings and said, how would you classify this? And so, and we tried to put this in.
We have an exciting life, you know. So.
Well, it was quite fun, but...
Dirk's idea of a good night out, you know.
But at least we had some pictograms at the end to show this is unilocular, this is multilocular solid. But this was not evidence-based, this was authority-based, this was simply based on our experience. And if you then come to the simple rules, this is more evidence-based because it showed that if the largest diameter of the solid part was less than 7 millimeters, it's very unlikely to be malignant. And that's why you have this discrepancy between the first terms and definitions and then the simple rules.
Yeah.
So simple rules are evidence-based. The terms and definitions is simply how do we describe things. And we said population, if the height is 3 millimeters or more, it's a population. If it's 2.9 millimeters, it's an irregularity.
Okay, gentlemen, sorry, I couldn't.
Hi, sorry. Just a couple of questions on the Adnex app, because I found sometimes a bit confusing. The first thing is that I wanted to know is if it's more important the predictive risk or the relative risk in evaluating the risk of malignancy and the subtype of lesions. Because, for example, yesterday we saw in one of the examples you show a Krukenberg tumor that have a predictive risk that show a more benign features than the relative risk show at the end. But for example, in the app, you have just the baseline risk and the predictive risk, but not the relative one, which I think it's the more interesting and the more sensitive for the evaluation. Thank you.
That's an excellent question, and thank you for raising this, because it's a matter of debate how to use the Adnex model. I think the most important outcome is first to decide whether it's more likely to be benign or malignant. And for this, you need a cutoff. And Ben beautifully showed yesterday that you can use different cutoffs. It's a little bit depending on what you want to do with this cutoff. If you say, I need to have a safe cutoff to not operate this patient and to have conservative follow-up, then you should have a very low cutoff, 1%. If you use 1%, then you will almost never miss a malignancy. So then you have a safe group of patients for follow-up. But of course, it will not be the majority of patients. You can also use 3%, so it's really depending on your situation. Then the second thing is, the second cutoff is, do I treat the patient locally in my hospital and do laparoscopic surgery, or do I need to refer the patient to a specialized hospital with an oncologist, because we know if it's cancer, the survival of the patient will be better. And then you can use a higher cutoff, and then you can use, for example, 20%, or even 30%, or even 50%. If your healthcare system is very limited in resources for oncology treatment, then you may choose 50% cutoff. But that's something that should be in future guidelines. So for example, in a country where there's very few cancer centers and places are limited, they really don't like to see benign tumors, use a cutoff of 50%.
So shall we move on to this issue about relative risks?
Yes, but then, so that's the first step. Yes, that's step one. Sorry for my long, but I want to really make it clear because it's so important. So that's cutoffs, benign, malignant, conservative management, no. And then in the second step, if you think it's malignant, so if it's above this cutoff of malignancy, 20%, for example, then you look at percentages. And our statisticians will say, well, the highest percentage, that's the highest risk, because the model is well calibrated. That means if it says there's 50% chance that it's benign tumor, well, in reality, it's 50% chance of a benign tumor. And if you say it's 15% chance that it's, or risk that it's a metastatic tumor, it's 15%. So 50 is higher than 15, so it's more likely to be benign. But because you first look, is it benign or malignant, then you look at the malignant group, if it's probably malignant, then you look also at relative risk. And then you will see this possible malignancy has the features more than other Iota patients
of a benign, of a borderline tumor, or maybe a metastatic tumor. Because in the whole group, there's only 4% of metastatic tumors. If your patient has a risk of 16%, then you know this is 4 times higher than baseline risk. So the relative risk of metastatic tumor is 4. So beware, this is possibly a metastatic tumor. And what should you do? Mammography, colonoscopy, full body MRI, just to exclude the presence of a primary tumor.
Dirk, do you think we should update the app with the relative risk so that people don't have to calculate it themselves? Wouldn't that simplify the use of the interpretation?
If you see the model, for example, in the Samsung machines on our website, the relative risks are clearly indicated.
Are they?
Yes, they are clearly indicated. So this is very useful, I think, because then you can see both the percentages, but also the relative risks. And I think these are very useful because then you know this patient is much more likely than other Iota patients to have this metastatic tumor. So then you can see in my center from a relative risk of 2, I will do this or this.
Hang on, Dirk. Have we answered the question for you? I'm not sure. Yeah. Okay. Do you have the microphone still? Okay. Shall we just, perhaps you can pursue afterwards. I mean, I do think it's interesting. People do find it difficult kind of putting together the relative risk versus the percentages. I agree, and I think I think we're aware of that, and I think maybe we do have to do something to try and explain that a little, even in the app, would be helpful, I think. It's a useful message. I'm not trying to, you understand, I think there's some other people want to ask questions. I'm not trying to brush over what you said. There was another question. 2 people over there. Who's first? You first? Okay. Talk, just stick the box in your face in the nicest possible way.
Sorry, the clinical problem is if you have running a clinic in a region and you can't discharge some of the patient from the clinic, you can't do the surgery, so you'll be accumulating a massive number of patients over time. That has cost for the health economy as well as the stress for the patient and the clinician. So I think in the future we should focus on how long we are going to follow up this patient before discharge and how frequently we have to follow up. For example, some of the cases shown yesterday that the malignancy develop over the time, 36 months, 12 months. So I think we have to focus on when are we going to discharge from this patient?
Well, let me ask you a question then. What would you say if you had a mass, and what risk of malignancy, if you had a patient in front of you and you came up with a risk of X, would you say, fine, you can, I'll see you in whatever number of months? What is your risk threshold in your head for cancer? 1%, 0.5%, 10%? What is it?
I take as less than 2% you can follow up. But that is not acceptable for some of my colleagues or my patients. That is the problem. So.
Well, that's exactly right. You cannot have a rule which is not acceptable to clinical judgment. For example, you have to look at the patient in front of you. If it's a very young patient deserving or still wishing to become pregnant, you will treat her in a different way than if you see exactly the same tumor with the same risk in a 55-year-old lady. So it's so this is clinical judgment.
Nothing wrong with being 55, Dirk.
And it only helps if you have an objective measure, and then you can base your guidelines upon this. So I think my hope is that in the future, organizations like NICE and RCOG and so will take this model and say, well, this is our cutoff. And in that case, we will propose this type of management. But it will always be you as a doctor, you will be in charge, and it's not a model that is in charge.
But I think that Iota 5 will give some useful information on that, I think, in terms of follow-up and what's okay, because I think there are going to be masses that, you're right, one of the problems with Iota 5 as a study, even for the people doing the study, was the accumulation of a large number of people who are coming back to the clinic sometimes, or even knowing. A lot of clinics function in a way that they'll have patients coming from elsewhere and they get sent back, and it's hard to know what happens. So I think there will be a group of people who perhaps have one or even a scan after a few months. Hopefully we can define something that maybe even at 6 months, and then they're just discharged without the need to be seen again. I think that's what people need. You're absolutely right. I mean, otherwise, in a sort of NHS system in the UK, it's just impossible. I know there are other different health systems. That's okay. So I understand your problem. But it does kind of come down to what your perceived risk is, and also of colleagues and other people around you. You know, because we all know the reality is the statistics can show one thing, but if you're in your clinic in the UK and you send a patient away and they come back with cancer, even if you can say the risk is less than 1%, you're going to get screwed. Next patient. Someone else had a question. Was it you? I think. No, you're just holding the box. Waving there. So.
Good morning, Jigan from Austria. We've been using for some time the ADNEX model to our patients that are being referred to our center. And we always run the ADNEX parameters, and it performs very well. Then we order some CA125, and then it's being discussed constantly with our senior colleagues. So now it means that we're dropping out the CA125. Because could you comment on that? Because the numbers you show basically might cause some misunderstanding in the community.
So what are you saying? You've stopped measuring CA125?
Not at all, but we've been making decisions prior
whether to drop it. Okay,
so,
well then basically CA125 doesn't change the benign versus malignant characterization. It changes the subclassification, particularly between earlier stage borderline and late stage disease. But Dirk can talk about that. Dirk? Yes?
Yes, true. So I think it would be wrong to look at the next model and then have CA125 and then only focus on CA125. You have to integrate it into the next model and then look at the overall outcome. And you will see that it will not really change the prediction whether it's benign or malignant, but your subclassification will be better. But don't look at CA125 in isolation, because otherwise you will make more errors.
No, I think the question you're asking is, do you need to keep on measuring CA125 if you have the ADNEX
Not really.
Model? That's your question, really, isn't it?
Yes, exactly.
I would argue you don't for most masses where you're just saying benign or malignant, and perhaps it depends when you take the blood test. You know, if the blood test is available or it's taken before the patient comes for a scan, then it's tricky. If you say on ADNEX it's cancer or malignant, shall we say, then having that blood test may be helpful to subclassify that mass. So if a patient comes along for a scan and it's cancer versus non-cancer, you don't need CA125 in terms of overall performance. Ben's going to shoot me, but I think he'd agree. And then Ben himself said it's the group in secondary care or triaging the malignancy for, if you like, personalized care, where the addition of CA125 to ADNEX is going to help improve the subclassification, I think. So you could drop it if the logistics of how you run your clinic works, and then selectively use it to help you triage the patients further. And one question.
And also most oncologists will prefer to have CA125 in every cancer prior to surgery and to see whether it's a good biomarker for follow-up.
So we have one more comment and then we're going to have coffee because Dirk promised you to have a proper coffee break.
Yes.
Povilas.
True. The risk model is applicable to 100%.
Yes.
So you will get an outcome in all patients.
Okay. So the question was, simple rules are applicable to 75%. What about simple rules risks? Simple rules risks you can use for all patients. And that's a paper which actually I think is in the American Journal, and it's open access if people want to read it. So that's something you could follow up on perhaps. Antonia Testa is going to get the last word for this session.
Just a question to
Please have a seat.
all of you. We traveled a lot all around the world, teaching Iota terms and definition to Asian colleagues, to South America, North America. Which parameter do you think that are the most confusing or difficult to share with the other colleagues? I mean, because I found some problems around the world. I want to share with you the experience to teach Iota terms and definitions.
Antonia, we said the last word. You're not going to share your experience around the world the whole time. but
I didn't quite understand. You mean which variable? which parameters in the model causes the most confusion? Difficult to understand, to interpret, to use. I think probably solid component causes a lot of confusion, because people still tend to classify the white ball in a dermoid cyst as a solid component. And also, even if you know the definition, you have this problem that sometimes it's not so easy to know, is this solid tissue, or is it a blood clot, or is it a lump of mucus, or is it... So I think that's the most difficult. And still it's very important variable. It's an important variable.
Yes, my experience is also solid and papillation. So papillation, by definition, is solid tissue. So as soon as you have one papillation, the cyst is not unilocular, but unilocular solid. And if it's multilocular solid. So there's a lot of confusion about this.
Well, it's multilocular, who knows? Right, that's it.
I need a coffee.
That's it. Caffeine is the answer. Thanks very much for all the speakers.
Thank you.
I think we run to time.